Welcome to today's Explainer. If you're a medical student trying to wrap your head around how to manage complex patient cases, well, you're in exactly the right place. Today, we're going to virtually step onto the wards and figure out how to handle high-stakes diabetes cases together. We'll be breaking down the etiology, the pathophysiology, and honestly, the most important part, the clinical decision-making you need to confidently manage this disease.
Okay, let's kick things off by testing your clinical instincts. Picture this, you're the first one in the room. Your patient is lethargic, their labs just came back, and the blood sugar is a staggering 600 milligrams per deciliter. The nurse looks right at you for orders. Do you push aggressive IV fluids first, or do you immediately start an insulin drip? Keep your answer in mind as we work through this, because we're definitely going to return to this exact scenario later.
Here's our roadmap for today. First, we'll cover core pathophysiology. Then, we hit the lab for diagnosis, survive an ER crisis, and finally wrap up in the clinic with pharmacotherapy.
All right, diving into Part 1, Core Pathophysiology. We have to start by clearly understanding the biological foundation of the disease we're fighting.
Have you heard of the ominous octet? Well, it should absolutely be your primary mental model for type 2 diabetes. See, this disease isn't just about a simple lack of insulin. It's actually driven by 8 core pathophysiological defects. We're talking about decreased insulin secretion from the pancreatic beta cells, increased glucose production from the liver, decreased glucose uptake in the muscles, increased lipolysis, and a critically decreased incretin effect, meaning gut hormones like GLP-1 just aren't doing their job. Memorizing these 8 defects isn't just some academic exercise, I promise. It helps you understand exactly where our targeted drugs are going to intervene later on.
Now, you've also got to master the strict divide between Type 1 and Type 2. In Type 1, you're looking at an absolute insulin deficiency, right? It's caused by autoimmune beta cell destruction. So if you're suspicious of Type 1, you want to hunt for specific markers like anti-GAD antibodies or islet cell antibodies. Type 2, on the other hand, is a multifactorial beast. It starts with insulin resistance, which leads to early hyperinsulinemia, and then progressive beta cell dysfunction and failure. The risk factors here are pretty classic: central obesity, a sedentary lifestyle, and family history. The treatments for these two entities are entirely different, so distinguishing them early on is absolutely vital.
Moving on to Part 2, the lab. Let's break down the diagnostic logic and how we interpret these results.
I want you to apply this logical step-by-step process every single time you look at a basic metabolic panel to make sure you never miss the diagnosis. First up, check the fasting plasma glucose. An FPG of 126 milligrams per deciliter or higher, that's diagnostic. Next, you check the HbA1c. And finally, always assess for the classical clinical triad: polyuria, polydipsia, and polyphagia. If your patient is constantly urinating, extremely thirsty, intensely hungry, and they have a random glucose of 200 or higher, well, you've got your diagnosis right there.
So, if there's one crucial point to take away here, it's this single number: 6.5%. An HbA1c of 6.5% or higher is your definitive diagnostic cutoff for diabetes. This number basically tells us the percentage of hemoglobin that's coated with sugar, which gives us a super reliable 3-month average of the patient's blood glucose levels. Seriously, burn this number into your brain.
But wait, what if they aren't quite at 6.5% yet? Keep a really sharp clinical eye on patients falling into the pre-diabetes range. If you see an HbA1c sitting between 5.7 and 6.4%, or a fasting glucose between 100 and 125, alarm bells should be ringing in your head. This is your golden window. This is the exact moment where you sit down, have a serious conversation, and intervene with medical nutrition therapy and physical activity before they cross that permanent threshold into overt diabetes.
Okay, dial up your energy for Part 3, the ER. We're talking triage and managing acute emergencies.
The patient is crashing and you need to act fast. You absolutely must know how to quickly distinguish the two major hyperglycemic emergencies, DKA versus HHS. On the left, we have diabetic ketoacidosis. This is typically your type 1 patient. Because they have an absolute lack of insulin, their body panics and turns to lipolysis, breaking down fats into ketone bodies. This creates a really dangerous metabolic acidosis. You'll see that classic deep, rapid Kussmaul breathing, and you'll literally smell fruity acetone on their breath. Now on the right is HHS, hyperosmolar hyperglycemic state. This is usually your type 2 patient. They have just enough insulin to prevent ketosis, but their blood sugars climb astronomically high, often over 600. Their primary problem isn't acid, it's profound, life-threatening dehydration from massive osmotic diuresis.
So here is the answer to our opening question. When that patient rolls in with a sugar of 600, you always
Always push aggressive IV fluids first. Step 1 is normal saline to reverse that profound intravascular dehydration and get the kidneys perfusing again. Step 2 is the insulin infusion to stop the ketogenesis and bring down the glucose, and Step 3 is meticulous potassium correction. Remember, insulin drives potassium back into the cells. If you aren't watching their potassium like a hawk, you could accidentally trigger a fatal cardiac arrhythmia while you're just trying to fix their blood sugar.
But a quick warning here. Aggressively treating high blood sugar can actually swing the pendulum way too far the other way, causing life-threatening hypoglycemia. Whether it's from an insulin overdose or just a missed meal, a rapid drop in sugar triggers a massive adrenergic response: sweating, tremors, anxiety. If it drops even further, neuroglycopenic symptoms kick in, meaning confusion, seizures, or even a coma. The brain needs glucose to survive, period. So always be ready to push dextrose if you accidentally drop their levels too low.
All right, take a breath. The patient is stabilized. Let's move into part 4, the clinic, and talk about pharmacotherapy and stepping up management.
We need to design a long-term outpatient strategy using a rational, stepwise approach. You don't just throw random drugs at a patient, right? You build upon a solid foundation of medical nutrition therapy and weight reduction. If lifestyle changes aren't quite cutting it, step 1 is almost always going to be metformin. If their A1C stays stubbornly high, step 2 is adding a second agent based entirely on their specific patient profile. Step 3 means moving to dual or triple oral therapy. And finally, if the beta cells burn out completely, step 4 is stepping up to basal bolus insulin regimens.
What's really fascinating here is how these drug mechanisms map perfectly back to that ominous octet we talked about earlier. Metformin primarily works by decreasing hepatic glucose production. It's your first-line baseline controller. SGLT2 inhibitors work in the kidneys to increase renal glucose excretion. You're literally having the patient pee out the excess sugar. And as a bonus, they offer incredible cardiovascular benefits. GLP-1 agonists mimic gut hormones to boost the incretin effect, resulting in some pretty significant weight loss. And DPP-4 inhibitors, they simply prolong the action of the body's natural incretins. Every single drug has a very specific target. And this brings us to the core of modern clinical decision-making. You aren't just blindly following a flowchart to lower a number on a lab report. You're actively selecting agents that treat the patient's unique comorbidities to save their life in the long run. If the patient is dealing with central obesity, you're going to lean heavily toward a GLP-1 agonist. If they have established cardiovascular disease or heart failure, an SGLT2 inhibitor is absolutely the way to go. You have to tailor the therapy to the actual humans sitting in front of you.
As you adjust these medications, keep your eyes glued to these essential clinical targets. We're generally aiming for an HbA1c of less than 7%. We want that fasting glucose sitting nicely between 80 and 130, and the postprandial, or after-meal, glucose needs to stay under 180. Hitting these exact targets is how you protect your patient from devastating late-stage complications. Chronic hyperglycemia drives glucotoxicity, which literally damages every organ over time, leading to the big three: neuropathy, retinopathy, and nephropathy. By holding the line on these targets, you are saving their nerves, their eyes, and their kidneys.
Which brings us to a final thought. You now have the framework. You know the pathophysiology, the diagnostic cutoffs, the rapid ER protocols, and the stepwise drug mechanisms. But beyond the numbers, beyond the algorithms, how are you going to personalize care for your next diabetic patient? The real challenge, and honestly, the true art of medicine, is applying this knowledge with deep compassion to the person sitting in your exam room. Think about how you'll explain these life-changing interventions to them. That is the mark of a truly great physician. Thanks for joining me on The Words today, and I'll see you in the next explainer.